Welcome to the Explainer. Today, we're bringing you a super complete, high-yield deep dive specifically curated for medical specialists. We're unpacking Chapter 2, Section 2.2 of the European Society for Vascular Surgery, or ESVS, 2021 Clinical Practice Guidelines. Our absolute focus today? The exact diagnostic and investigational pathways for lower extremity venous thrombosis.
So let me ask you a question right out of the gate. When a patient walks into your clinic, can you confidently diagnose a DVT on clinical signs alone? I mean, we all look for that classic triad, right? Leg swelling, redness, and that localized deep pain. But is that really enough?
Well, the data from the ESVS guidelines gives us a pretty staggering reality check. Up to 80% of DVT cases might not be clinically apparent at all. Often, pain is literally the only presenting feature. That number alone proves that our physical exams, while definitely essential, are wildly insufficient as a standalone diagnostic tool. We need a rigorous, structured approach.
All right, so here's our clinical roadmap for today. 1. Suspecting deep vein thrombosis. 2. The Wells score assessment. 3. D-dimer measurement realities. 4. Ultrasound imaging strategies. 5. Advanced venography options. And 6. Classifying deep vein thrombosis.
Let's kick things right off with Section 1, suspecting deep vein thrombosis based on clinical features.
The golden rule here is that clinical features merely raise suspicion. They cannot definitively rule a DVT in or out. And why is that? Because the clinical overlap is just massive. Take a look at these common DVT mimics. We're talking about things like lymphedema, superficial vein thrombosis, post-thrombotic syndrome, cellulitis, ruptured Baker cysts, and even just routine muscle trauma. Because the pain and swelling in these conditions mimic DVT so closely, we absolutely have to rely on validated clinical decision tools to clear through the noise.
Which brings us seamlessly to Section 2, the Wells score assessment. Now, this is where we take our clinical suspicion and turn it into a quantified pre-test probability, using the validated Wells DVT score criteria. You assign points for things like active cancer, recent immobilization, localized tenderness, entire leg swelling, calf swelling over 3 centimeters, and so on. If the score totals 2 or more, a DVT is considered likely. Less than 2, it's unlikely. But pay special attention to that last criteria, subtracting 2 points if an alternative diagnosis is at least as likely as DVT. It actively forces us to consider all those mimics we were just talking about. And this brings up our first major ESVS guideline recommendation. It's a Class 1, strongly recommended action that a clinical assessment of pretest probability is performed whenever a DVT is suspected. But keep in mind, even in the unlikely or low-risk group, the probability of a DVT is still up to 5%. So the Wells score is not your standalone test. It's simply the gateway to your next move. Let's move into Section 3, D-dimer measurement realities. Transitioning into the laboratory phase, we hit our next critical layer of evidence. What's really interesting here is the stark contrast between sensitivity and specificity. The D-dimer test boasts a sensitivity of about 95% and a negative predictive value of 99 to 100%. That makes a negative D-dimer incredibly effective for rolling out DVT in patients with an unlikely pretest probability. However, its specificity is notably low, sitting anywhere between 35 and 55%, which means, unfortunately, it's plagued by a high rate of false positives. And the reason for this low specificity? Well, it's practically a clinical headache. Elevated D-dimer flags increased fibrin degradation, which is caused by venous thrombosis, for sure. But it also naturally increases with older age, infections, active cancer, and pregnancy. So a positive D-dimer doesn't suddenly mean DVT confirmed. It just means, all right, proceed to imaging. Let's move to Section 4, ultrasound imaging strategies. This really builds out our clinical algorithm. ESVS Recommendation 3 is another Class 1 recommendation, stating that for patients who do require imaging, ultrasound is the undisputed standard first-line modality. But, as you know, not all ultrasounds are deployed equally. Let's look at compression ultrasound, or CUS, versus whole leg ultrasound, WLOS. CUS is a quick 2 or 3 point check, usually at the common femoral and popliteal veins. It's fast, sure, but it can't exclude an isolated calf DVT. On the flip side, whole leg ultrasound scans the entire deep vein network. It's going to catch those calf DVTs, but it demands highly advanced skill, takes way more time, and risks the overdiagnosis of isolated calf DVTs of uncertain clinical significance, which of course can lead to unnecessary anticoagulation.
So, how do we solve this dilemma safely? The guidelines point us to the Palladio study algorithm for triaging patients. It breaks down like this. Group 1, if pretest probability is unlikely and D-dimer is negative, DVT is excluded. Group 2, if pretest is likely or D-dimer is positive, perform a CUS. And Group 3, if pretest is likely and D-dimer is positive, perform a WLUS. By adopting this exact approach, the use of WLUS was reduced to just 35% of suspected patients, all while keeping missed thromboembolic events safely under 0.3%. That's a huge win.
But what happens if your clinical suspicion remains stubbornly high even after a clean initial scan? Here we have ESVS Recommendation 4. This is a Class 2A recommendation to consider a repeat ultrasound after 5 to 7 days if the pretest probability was likely, but that initial compression ultrasound came back negative. Let's look at Section 5, Advanced Villianography Options. So what do we do when ultrasound simply isn't enough? Or maybe it's just technically unfeasible. These are your Class 2A alternatives. Computed tomography venography, or CTV, gives us excellent spatial resolution for evaluating those tricky pelvic veins and the inferior vena cava. But it comes with some heavy drawbacks, significant radiation exposure, and the need for iodine contrast. Then you have magnetic resonance venography, or MRV. This is fantastic for spotting extrinsic pelvic compression, and it avoids radiation entirely. However, it usually requires IV contrast, it's a lot less available, and it's quite expensive. Neither of these replaces ultrasound as your frontline tool, but they are absolutely vital backups. And finally, Section 6, Classifying Deep Vein Thrombosis. We've officially arrived at the end of our diagnostic funnel. Once confirmed, accurately classifying the DVT dictates your entire course of treatment. First, we have to classify by etiology. A provoked DVT occurs with clearly identified environmental or acquired risk factors. These could be transient, like a recent major surgery, or persistent, like an active cancer. An unprovoked DVT, on the other hand, occurs in the absolute absence of clearly identifiable risk factors. This distinction is critical because it fundamentally alters your patient's long-term risk of recurrence if anticoagulation is ever stopped. Second, we wrap up by classifying by anatomical level. Iliofemoral DVTs account for about 30% of cases, and they usually present with the most severe symptoms. We're talking massive swelling and pain due to obstructed pelvic outflow. Then we have femoropopliteal DVTs, and finally, isolated calf DVTs, which account for another 30% of cases, but can present with highly variable, sometimes completely silent symptoms. So, we've successfully navigated from initial clinical suspicion all the way down to a confirmed, properly classified diagnosis. But here's the provocative question I want to leave you with today. With the diagnosis confirmed and the DVT accurately classified by both anatomy and provocation, how do we optimally tailor our anticoagulation strategy to match that patient's specific recurrence risk? Well, that is exactly what we will be unpacking in our next explainer, focusing on ESVS treatment protocols. Until then, keep analyzing those algorithms.